you for inviting me to present this topic, single visit endodontics, on this wonderful platform. Any queries related to my presentation, even later, please feel free to approach me on my page, Upskill Dental Academy, on Facebook, Instagram. Please watch my videos related to endodontics on my YouTube channel, Upskill Dental Academy, and you can address your queries there too. So, coming to our topic. Endodontic therapy is a series of interlinked steps that aims to preserve or heal the periapical tissues and keep proper tooth function. What is important here is that it is a series of interlinked steps which you are very well acquainted and or probably familiar with the finer intricacies of the same through all the great mentors, the best mentors in endodontics who have presented various topics in detail. And today, as we understand that root canal treatment is all about preserving the functionality and form of the tooth and bringing back the tooth from resolution of its periapical inflammation through single visit endodontics is what will be the topic today. So first of all, when we can achieve everything through multi-visit, then why did this question of single visit crop up? The question in our minds right now is why single visit endodontics? And if we were to do, considering the series of interlinked steps, the protocols that we have to follow, how would we execute the same in a short period of time? And what are the requirements to achieve the same successfully, consistently, predictably? Let us take an example here. Let us look at these runners. Now, there are two main competitions in athletics. One is sprinting and one is marathon running. Now, both these athletes, they condition the same group of muscles. They perform the same act of running. However, they are at two opposite ends of the athletic spectrum. Why? Sprinting, say for example, a 100-meter race, lasts just a few seconds and the athlete has to give his everything that he has learned and conditioned in that short period of time. Whereas a marathon requires the person to last, to maintain consistency and focus and perseverance till the very end of the race. So this is something similar when it comes to comparing single visit endodontics and multiple visit endodontics. So what are the factors that we have to consider when we are considering single visit endodontics? First and foremost is the operator's skills. Unless and until an operator has learned all the techniques and skills which are essential to execute each and every step of root canal treatment, it would be prudent not to attempt a single visit endodontics. Scientific knowledge which is acquired by studying in detail scientific papers and studies which have been conducted on various techniques, various armamentarium, and everything that you have to know about the root canal system. Coming to armamentarium. There is a host of armamentarium available related to root canal treatment. Nobody can possess all of them. What the clinician has to do is to understand the optimum armamentarium that is required in his setup to execute the single visit endodontic treatment successfully, know the clinical techniques required and adapt and practice that one technique which suits his clinical setup and budget to predictably perform the root canal treatment, to understand the difference between periapical status and pulpal status and what are the symptoms that would probably guide you towards case selection for single visit endodontics, to have trained assistants. Now, trained assistants is actually a big thing. Your assistant can play a very big role in single visit endodontics, right from sterilizing all the armamentarium that you need for your single visit treatment to make sure that all the gadgets which are required for single visit is properly charged and ready to make sure that they assist you at the right time for rubber dam isolation. To provide, if you train the assistants in measuring the working length, they can probably give you the rotary files measured to working length mounted on the endomotor. That saves a lot of time. They should learn how to clean the flutes. They should know how to examine the file flutes under a magnifying lens. These are all basic investments and they can aptly adjust and assist you during the process of irrigation by providing a continuous supply of irrigants and suctioning adequately, and of course, even assist you during obturation. So that is the role of a well-trained assistant. If possible, it is better to have four-handed or six-handed dentistry when you perform single visit endodontics. Preparing the patient is another important thing which every clinician should do. Patients come to the clinic with various thoughts in their mind regarding root canal treatment. They have various fears and many other things. So one thing is to explain the patient about performing the treatment in one visit. Make sure that the patient is accepting this concept of single visit endodontics and pre-schedule an appointment so that the patient is comfortable at the time of appointment. For a beginner, I'm specifically targeting this for a beginner because when a beginner looks at those beautiful obturations and those superhuman excellence that is exhibited by great mentors in root canal treatment, it's but natural we are fascinated by the challenges that root canal treatment offers and also by the mystery that the root canal system offers to you. However, every master was once a beginner, and all of us, everybody, be you a mediocre, a clinician, academician, or a master, we all began with the fundamentals. And hence, you have to invest a lot of time in mastering your fundamentals. Get well acquainted with the techniques of root canal treatment, learn the armamentarium used in root canal treatment in detail, get well acquainted with the anatomy of the root canal system and the challenges that it offers, and work very hard on improving your skills so that you're able to consistently perform all the steps of root canal treatment before even venturing into single visit endodontics. Remember, the master has failed more times than a beginner has ever tried. And most importantly, the rule in single visit endodontics is do no harm. Single visit endodontics is a natural corollary to the transformation and treatment modality of endodontic therapy to an era of rotary endodontics from an earlier era which consisted of handheld files. It is practiced since decades and it is not a new concept. Believe me, when I was a postgraduate, all my root canals which were performed in single visit were performed with handheld files. Things became much easier with the introduction of endomotors in the years to come. The main criteria for single visit endodontics is fully understanding the principles of endodontics and the objectives of root canal treatment and developing the ability to exercise these principles efficiently. The factors that determine success is mainly, predominantly, case selection. Careful case selection by evaluating the patient history, the clinical examination thoroughly, radiographic evaluation, and for some reason if you have doubts with the periapical radiographs which you have taken say multiple number of times on that day, you can always refer for a CBCT, but careful case selection is of prime importance that determines success. Clinician skills, we have already discussed it in more or less in detail. Now, when I say developing and mastering the technique and skills, it involves two important elements, and that is practice and consistency. Practice can be easily performed on extracted teeth. And what do you learn when you practice on extracted teeth? First of all, you get acquainted with the armamentarium that you will be using for various steps of root canal treatment. You'll get acquainted with the complications of root canal anatomy when you try it on different extracted teeth, and you're conditioning the muscles which will be used repeatedly to perform filing and obturation and irrigation. So you're improving your ergonomics while doing so. Now, one of the biggest advantages of practicing on extracted teeth is being able to visualize the root canal anatomy in multiple planes and understanding the concept of multiplanar curvatures, understanding abrupt curvatures, etc. For example, this radiograph is a conventional radiograph of a mandibular molar where files have been placed in mesiobuccal and mesolingual canals. The conventional view shows that there is a gradual curvature in the apical third. Now, suppose we were to take a different view, say from the mesodistal aspect, you can see a different story. The canals are more or less gradual in the major part of the root canal system, but there is an abrupt curvature in the mesobuccal canal in the apical third. Now, this would never be judged by a clinician if he was working on a patient. So, what we learn by practicing on extracted teeth is be prepared for something unexpected to be present in the root canal system. Consistency, however, can be only developed by working continuously on actual cases and repeatedly taking challenges step by step. So, the clinician has to understand that single visit endodontics is not about finishing fast, it is about finishing well in optimum period of time, and there is no element of speed involved in this entire effort. Whatever speed you acquire is a consequence of you mastering the skills and steps in root canal treatment. Tactile sense is a very important element which every clinician has to develop if he has to consider performing single visit endodontics. By definition, it is the sense of touch, specifically the information received from varying pressure or vibration against the skin. Tactile sensation is considered a somatic sensation, meaning it originates at the surface of the body rather than internally. Now, this is exactly what we perceive when we place a pre-curved file into the root canal system. By means of the surface of the skin on your fingertips, you are actually perceiving the root canal anatomy, the curvatures, the collagen, the denticles, and all those obstructions which come in the way. With repeated practice, you will actually be able to understand the root canal system three-dimensionally just by using your tactile sense. However, it requires a lot of practice. Know what you're dealing with. When it comes to single visit endodontics, we are specifically limiting our root canals to those cases when the pulp is inflamed, but the periapical tissue is relatively intact. This inflamed dental pulp is predominantly, or rather, an organic tissue, which is a viscous connective tissue of collagen fibers and organic ground substance. Now, this is very important when it comes to later stages of root canal treatment. Focus on the mechanical objectives of root canal treatment. That does not change. Develop a continuously tapering conical form in root canal preparation. Make the canal narrower apically with the narrowest cross-sectional diameter always across the terminus, and prepare it in multiple planes as nature has actually made the root canal. Never ever transport the foramen and keep the foramen as small as practical. Now, for example, look at these cases which are on display. This patient was referred to me for re-root canal, but as you all can observe, there is an evident vertical fracture in this case. And you can observe the preparation. You can see that the mesiolingual and mesiobuccal canals are not conforming to many of the objectives, mechanical objectives. If you were to follow all the mechanical objectives, you can achieve a continuously tapering funnel. You can restrict your preparation to the apical foramen. You can make sure that your apical terminus is as narrow as possible. You can prepare it in multiplanar curvatures, and hence you have higher chances of achieving success in your preparation. The biological objectives suggested by Schilder include complete debridement of pulp space from the pulp tissue, confinement of instrumentation within the root canal, not forcing necrotic debris beyond the foramen, and creation of sufficient space for intracanal medicaments. Now, these objectives hold good till date, which have served the purpose over decades. So understand the importance of these objectives when you're learning the fundamentals of root canal preparation. Healing following endodontic therapy usually occurs following an accurate diagnosis and proper case selection, which are very, very important, and use of skilled techniques of treatment. Olliott in 1983 suggested criteria for appropriate case selection of single visit endodontic therapy. Positive patient acceptance of single visit endodontic therapy, sufficiently available time to complete the procedure, absence of any acute symptoms like pain, swelling, drainage via root canals, absence of anatomic obstacles, which means the case is complicated and requires time. So all the procedural difficulties should be dealt with in multiple visits. Positive patient acceptance. The patient has to understand the time required for the procedure to be completed in one sitting. The patient should be in good health to undergo the same. The patient should not have any condition which will restrict the prolonged mouth opening that is required to execute it in a stipulated period of time. Single visit endodontics is actually a boon for geriatric patients where repeated coming to the clinic for treatment would be a problem. Accurate diagnosis. When I mention accurate diagnosis with a radiograph, the clinician has to first of all learn to consistently take an appropriate radiograph and process it well. The radiograph should be actually useful. And whenever you're planning single visit endodontics, it is prudent that you take a fresh radiograph before you make a decision. In the radiograph, if you see any complications in the morphology, please go ahead with the CBCT. Do not take any hasty decisions. Intraoral periapical radiograph taken appropriately will show you proper tooth morphology. Always take it in more than one plane so that you can get a three-dimensional idea of the tooth morphology and many other anatomic factors associated with the tooth. Ascertain the cause of the dental problem. Again, think about the possibility of restorability of the tooth, the complexity of the teeth, the treatment that you will be dealing with. This will help any clinician to decide, first of all, whether you have the skills to perform treatment for this particular tooth. The presence of pulse stones and other obstructions means it is not easy to perform this in single visit, so better keep it for multi-visit. And always look for additional roots and ascertain the existence of root curvatures, which could be challenging. So from there on, you move ahead. Now, the difference and the similarity. Single visit procedures have to follow the fundamental objectives. The major difference is only that you can complete the entire process in one visit. And so there is reduction in chairside time without reduction in quality of treatment. Little difference exists between one and multi-visit therapy with respect to post-operative flare-ups, chances of successful healing, and acceptance by patients. And there are so many studies easily accessible suggesting the same. Care in diagnosis and case selection must be a part of the treatment since single visit procedures are not considered appropriate for every endodontically involved tooth. Now, this is very important. Post-operative pain of greater magnitude and frequency is created by inadvertently insulting the periapical tissues by over-instrumentation and overfilling. So, remember what I mentioned right at the beginning. Do no harm. Deal with what you have to deal. Do not touch whatever is normal and functional. So, both single visit and multi-visit root canal treatment can be executed efficiently with advanced diagnostics, heat-treated rotary files, advanced irrigation techniques, and simplified predictable obturation techniques. Now, finally, it boils down to three important qualities: a thorough knowledge, well-developed skills, and ultimately the desire to do a good job in the condition presented to you clinically by that particular case. So successful endodontics is actually a decision which is taken by the clinician. Remember, do not force the material beyond the foramen. Remove all the debris inside the root canal system. Respect the biology and anatomy. And both sets of objectives are equally important and connected, and scrupulous attention to detail is the order of the day. Remember, there are no x-rays, no graphs, no drawing, no pictures which will tell you how well you have executed the objectives. Only you know how well you have executed the objectives. So be true to yourselves to get the best results. One more important element that you have to consider is taper, because that will determine the final root canal dimensions, and that will determine how deep your irrigants can penetrate and clean the root canal system effectively. If the apical preparation could be kept as narrow as possible while increasing the root canal taper by using rotary systems, this would create greater deposits for the irrigation fluids. Now, another thing which we often forget, why to do it right the first time? What happens is, if you leave behind pulp tissue tags, they are uninfected tissue, no doubt, but upon degradation, they will create lesions of endodontic origin by production of lytic enzymes and byproducts leaching out of the portals of exit. Now, how dangerous is that in causing a reinfection? Whenever bacteria colonize the root canal system, a stable infection is created by them creating biofilms where interdependency of bacterial species is noted. They create a toxic environment, and when you perform root canal therapy, your chemical and mechanical debridement kills the bacteria directly by interfering with the environment and indirectly by killing one species of bacteria and breaking that balance which they have created, the toxic balance, the physiological balance, and depleting them of nutrition. The surviving bacteria, mind you, are physiologically strong. They resist the changes which are brought in by chemomechanical preparation, no doubt. That means they can also survive in severe nutritionally depleted conditions, which means a poor first attempt at root canal treatment will lead to a more recalcitrant infection to attempt the very next time. So do it right the first time and don't create any harm. Always attempt a comprehensive, predictable effort when it comes to single visit endodontics. It may be significant to note that the only tool and probably the most vital tool to predict the prognosis of the treatment that you have done in one visit is your post-operative IOPA, the radiograph. But unfortunately, it is significant to note that a perfect appearance of a root canal filling in the radiograph has limited predictive value when it comes to the apical seal. It has a few advantages though. You have decreased the number of operative procedures and therefore lesser steps of administering anesthesia, gingival trauma from rubber dam applications, as well as eliminating risk of inter-appointment leakage through temporary restorations. It is less time consuming, resulting in less cost to the patients. It is not just the clinical cost. Just think about the effort of coming and going repeatedly to the clinic. Whenever it is possible, you should attempt single visit. Now, finally, the indications for single visit endodontics. First of all, when you have teeth which have isolation and sealing problems and which have a pulpal status which is amenable to root canal treatment in one visit, that is those which have subgingival breakdown, coronal walls are missing, full coverage have where you are planning to give a full coverage crown, they are ideal for single visit treatment. Anterior aesthetic problem. I think the most common problem which goes in for single visit endodontics is a case of trauma where there's a horizontal fracture of the crown at the gum line and you have to give, you have to perform single visit and then you have to place a temporary post and give them a temporary crown to maintain aesthetics. Also carious lesions which have extended subgingivally, so there is no other way where you can maintain aesthetics in anterior teeth other than by performing a root canal treatment and giving them a full coverage treatment. Restorative consideration. Sometimes the cases that fall in this category, they do not have any pathology in the pulp tissue, but the restorative reasons become the cause for root canal treatment. For example, if a tooth has to be considered for an overdenture abutment or anterior teeth, which you are considering for full crowns to realign them, sometimes, I mean, once upon a time, we were considering them in most of the cases, but now we have better options. Teeth with severe coronal breakdown that cannot be possibly restored with a restoration because of loss of tooth structure, that is very evident in attrition. Teeth that require preparation that would result in pulp exposure. This happens often in cases where you're realigning or changing the occlusal in some cases for specifically designed restorations. Vital exposure and symptomatic pulpitis. Now, teeth containing vital pulps, those with pulp exposures caused by trauma, by caries, or mechanical reasons, and teeth that exhibit clinical symptoms to heat or cold, but not to percussion, are ideal cases to be considered for single visit endodontics. Remember, the vital pulp is a situation where the pulp is only superficially infected with the microorganisms. The root canal is free of bacteria relatively. And if you provide an aseptic chain of treatment, you can successfully execute single visit endodontics as against a pulp which is necrotic, which is loaded with bacteria. There is evident periradicular disease. You have to go through several sessions, clean the canal system thoroughly, irrigate, place an intracanal medicament, and probably consider an obturation in the subsequent appointment. The single most consideration or the key factor which helps you execute single visit endodontics successfully is aseptic conditions. How do you maintain aseptic conditions? Aseptic conditions is almost like having a surgical environment while you're performing the root canal treatment. So that is possible by having an effective rubber dam isolation, which is moisture free, which makes sure that this isolation is a stable isolation which will last you till the end of the treatment, and you can execute all the steps of the treatment without contamination. The second way you maintain aseptic conditions is ensuring that you have autoclaved all the instruments which are being used inside the root canal. It also means, suppose you are performing root canal in single visit on multiple teeth which are adjacent to each other, we do not know the bacterial colonies which are colonizing the adjacent teeth. So if you're using a file in that tooth, you cannot use the same file ideally in the adjacent tooth because you're inoculating those bacteria and microorganisms into the adjacent teeth. So this is where your assistant can play a very important role in segregating your armamentarium and helping you in further maintaining aseptic conditions. Pre-endodontic buildup. Now, what is this pre-treatment? We all know the pre-endodontic buildup. It's a part of pre-treatment in endodontics. It is all those techniques that prepare for endodontic therapy that simplifies optimal isolation of the operating field. So before beginning a definitive endotherapy, you have to remove the caries, you have to re-establish the contours of the teeth and create those four walls which are missing. And that is your pre-endodontic buildup. Now, when you're performing single visit endodontics, you have to perform this in optimum time. So this is not a time when you would actually consider using some aesthetic restoration to build the wall, etc. You can also make do with a well-built wall using liquid damp because it suffices that 1 hour or 2 hours during which you will be performing root canal treatment. It will act as a stable wall, as a reservoir for your irrigants. It will help you in stabilizing your rubber dam clamp. It will help you as a definitive stop for your working length measurements and probably everything that you will require in that stipulated time period when you're performing single visit endodontics. So, pre-treatment would involve removal of caries, defective restorations, gingivoplasty or gingivectomy where needed, and reinforcement of the remaining structure. Access opening is the key to successful cleaning, shaping, cleaning, and three-dimensional obturation of the root canal system. According to Krasner and Rankow, attempting to treat the root canal system without detailed anatomic description would be equivalent of a physician looking for an appendix without having read Gray's Anatomy. Their work is wonderful, and the laws of orifice location recommended by Krasner and Rankow are an integral part of root canal treatment. Following these laws will help you in finding the root canal orifices, finding additional canals easily without causing any damage to the floor of the pulp chamber. Now, when we are working in the pulp chamber, we are working at a depth of 6 to 7 millimeters from the occlusal surface of the tooth. So what kind of visibility would you have under such conditions? We have to use burrs which have long shanks so that you get good visibility once you are into the pulp chamber. So these surgical length burrs, you have a wide variety. You have to make a choice based on your economics and your clinical conditions and how many cases you'll be doing in a day. Front surface mirror is a very important investment, especially if you're working with magnification tools. Use an endodontic spoon excavator to remove those tissue tags and pulp tissue which is present inside the pulp chamber. Always invest in a DG16 Explorer, a very important tool in locating root canal orifices. A JW17 Micro Explorer, which is an excellent tool, just like the DG16 Explorer. Ultrasonics, they are my favorite, because it does not have a head. So it eliminates the bulky head which you have in those hand pieces which obstructs your vision. So if you were to work with ultrasonics, this is how your visibility of the pulp chamber would be. If you work with long shank burrs, the handpiece head kind of blocks your vision to a significant extent. So make your choice and work smart, because you can still work with your handpieces, but the time taken would be more. When you know that you have to execute the task in optimum time, with the patient convenience and comfort in mind, you have to opt for smart choices. Always use a safe end burr when you're working in the pulp chamber. Make sure you do not distort the anatomy of the pulp chamber so that you can efficiently apply all the laws of orifice location suggested by Krasner and Rankow, which have been discussed in detail already. What is a JW17 Micro Explorer? Manufactured by Clinimed, it provides a safe way to punch a thin layer of secondary dentine in order to locate hidden, receded, mineralized orifices of the canal. They say that in comparison with the DJ16 Explorer, the amount of dentin and mud that it produces, which could probably block and cause a little more effort in locating the canals, is minimized by using this Explorer, which has a finer tip. What are the points we have to note while opening an access, that too in single visit endodontics? See, when you're doing single visit endodontics, we are mainly dealing with a pulp tissue. There's a lot of pulp tissue inside, which is inflamed. So avoid leaving behind remnants of pulp chamber roof, which will also mean that there are some remnants of pulp, tags of pulp here and there. Walls of access cavity should not deflect an instrument placed in the canal. That is, you're trying to get a straight line access. You don't have time. You have to use your time in performing the task efficiently and not in deviating and changing your angle of work, etc. You can keep that for multi-visit. Avoid damage to the pulp chamber, as I keep mentioning again and again. Avoid perforation of the pulp chamber floor. Easier to locate the canals following the floor anatomy. Believe me, if you have executed the access opening perfectly, your pulp chamber anatomy is intact. The floor funnels itself will guide your rotary instruments into the canal orifice, and that saves a whole lot of time, which would otherwise be lost in blindly looking for your canal orifice every time you put in a rotary instrument. Conserve the tooth structure. It will help you in preventing weakening and fracture and provides a good coronal and apical seal eventually. Remember, access means destiny in endodontic therapy. If you try to cheat access, he will hunt you all the rest of the treatment, in the words of Dr. Buchanan. The actual size and shape of an access cavity is actually determined by the age of the tooth. So the size and shape of the pulp chamber will therefore be smaller in older patients. Now, always avoid gouging the surface of the pulp chamber. This was a referred case. Now, I work with magnification, so I did not have any problems. The access was already open and there was clear gouging, which I could locate in the under magnification. Try to use safe end burrs and make sure you give optimal flare, not more than what is needed. You can clearly see that even under limited magnification, we can see the developmental grooves. We can see the orifices located at line angles. In fact, we can also see the approximate location of the MP2 in this maxillary molar. The dental operating microscope, a very important tool, especially for single visit endodontics, because it is a benchmark for unsurpassed premium lighting and magnification, which will help you in quickly locating the eye orifices. This is a case of lateral incisor, which I worked, where I found 2 orifices only because I was working with magnification. So it is one of the single most important applications of magnification in root canal treatment, especially single visit endodontics. Not only that, it will also help you locate accessory canals, hidden canals, obstructions, and pulp calcifications. So that will reduce the chances of a perforation. Imagine having a perforation in single visit endodontics will change the whole story. The equations will change. You'll have to immediately move on to multi-visit. So every step has to be precise, crisp, well planned, practiced, and studied before executing. Vital pulp removal. The aims are similar in removal, but not identical, because here you have an inflamed pulp tissue, but it may not contain that many microorganisms which should have been present in a necrotic pulp. So whenever I open a root canal access for single visit endodontics, I always aim at optimal access, because I know that I will never be able to access the root canal chamber ever again. So I have to make sure that I have enough access in so that I can clean and shape and complete my obturation successfully with precision in stipulated time period. Now, if you retain the pulp chamber anatomy, you will do a great deal of good in preserving the pericervical dentine, which is essential to have longevity in functionality of the tooth. Coming to establishing the glide path. The glide path is a pre-existing path, which is a tunnel which extends from the root canal orifice to the apical terminus. We locate the root canal orifices and then we negotiate it with a pre-curved stainless steel K-file, which is inserted into the orifice and gently glided where there is minimum resistance along the length of the root canal up to the apical terminus. Pre-curving the file helps you bypass those denticles and collagen tissue which could act as an obstruction in reaching the apical terminus. These are, I would say that the glide path is one of the most important steps in single visit endodontics, because what you would do in the next 10 minutes will determine, or you can say it can make or break your case. Now you require total alertness and absolute patience because you're using a brand new K file. It remains its sharpest in the first 10 to 15 minutes, and your tactile sense is very good at that time because you're extremely alert and patient. And when you utilize all these features to the maximum, you'll be able to quickly establish the glide path. Even a few moments of neglect or lack of concentration could lead you to loss of several millimeters of working length, which means imagine the bacterial colonies that could be present in that many millimeters of the root canal, which you can never probably negotiate. Or even if you want to negotiate, how much of time would you spend to re-establish your entire glide path? So remember this, that those 10 minutes are very important. If you work hard in those 10 minutes, then you will have no problems in completing your rotary preparation as well as your irrigation and obturation. Now, once you have established the glide path, you have to use short vertical strokes of very small amplitude and enlarge the canal dimensions to a size 10K super loose. A super loose means your file is actually slipping smoothly into that space without effort or effortlessly. Why do we have to pre-curve the file? When you pre-curve the file, it helps in reducing the restoring forces by achieving an accurate match of the canal, and that is possible only in one particular position or orientation. It is very important to control the vertical amplitude of your strokes when you're filing initially, because one bit of neglect and there will be a great mismatch. So that is very important while establishing glide path. So endodontic glide path could be difficult if you use a size of a file too large. If you use a file which has a shaft too large, so always change over to smaller files. If you encounter bifurcations, there is a good chance that the tip of a small sized file could break and it could go unnoticed. So all these things should be taken into account while performing the glide path perfectly. Working length. Working length is a length which you will establish from the coronal reference point to the apical terminus. The coronal reference point is easy to establish. Make sure that the stopper of your file is sitting steady on the surface of the tooth. Do not take an odd angle or do not take an imbalanced stop, because that would keep changing as you continue with the process of cleaning and shaping your root canal system. The apical terminus. Now, ideally, the apical terminus is set at the minor apical foramen, which is the apical constriction, which is the narrowest diameter of the tooth, located 0.5 to 1 mm from the major apical foramen at the root canal terminus. According to Ricucci and Langeland, the apical constriction is the narrowest part of the root canal with the smallest diameter of blood supply. Thus, it creates the smallest wound site and the best healing condition, which is why we choose the minor apical foramen as the apical terminus for your working length. A few words about hand files in root canal treatment. Now, since stainless steel files are not considered to be a part of any system, it's misleading for many to think that it's a relic of the past. But unfortunately, no, or fortunately, no. It is impossible to skip a hand file altogether. There are so many phases in the preparation of root canal systems where you cannot do without a hand file. Right from establishing coronal patency to canal negotiation to establishing apical patency to creation of a glide path to working length determination, enlargement of the body of the canal initially, recapitulation for establishing patency, bypassing a ledge, bypassing separated instruments, or even to read the canal anatomy, you need a hand file, and they are indispensable. Know your root canal system. I think this is an integral part of the fundamental basics before you even put your hands into single visit endodontics, because the root canal system is known for and is fascinating to us because of its complexities. As the Greek physician Hippocrates postulated that the anatomy is the foundation of medicine, and root canal anatomy is undoubtedly the foundation for endodontics. Guido Fisher presented the challenging nature of apical root anatomy for the first time in 1907. The complexity and unpredictability of the root canal morphology led him to coin nowadays widely used term the root canal system. We are fortunate that micro CT studies offers us a simple reproducible technique for 3D non-invasive assessment of the anatomy of the root canal systems. A few of the variations, probably which we can actually call them a norm that we often encounter in root canal systems, which we have to be well acquainted with when we perform any root canal treatment, be it single visit or multi-visit. One is the multiple portals of exit. Now, generally, when you reach the apical terminus, you are just negotiating your canal to the largest apical foramen and something which is easily accessible. There are always many other portals of exit which are present, either in the form of accessory canals or otherwise. So, this is how an obturation would show the multiple portals of exit. Always be prepared for an apical delta, which is created by an accessory canal, which is an offshoot from the main canal. So this radiograph, this obturation shows an apical delta, and this is a lateral canal. A lateral canal is like an accessory canal, but it is more or less at right angles and an offshoot in the middle thirds of the root canal system. And here you can see the lateral canal also. Now, what we have to remember when you're doing single visit endodontics is the inflamed pulp tissues may not be, it's not mandatory to actually access those lateral canals and remove the inflamed pulp tissue. Whereas it is mandatory in necrotic infected root canal spaces to somehow make every attempt to access, clean and seal those lateral canals whenever possible. Then comes the isthmus. The coronal third of the canal isthmus can be tucked with small abrasive ultrasonic tips. You will also find splits in the apical third in the normal canal anatomy. You can be prepared for various splits in the palatal canal. You can find variations in canal anatomy in the apical third. You will find loop. Loop is nothing but two accessory canals joined together as an offshoot from the main canal. Additional canals in radix endomolaris. Another important thing, the significance of isthmus. Now, why do we have to clean the isthmus? Tissue left behind the isthmus can serve as a nidus for infection and it can lead to failure of root canal. So, using magnification and using ultrasonic tips, you can efficiently clean the isthmus prior to irrigation and obturation. What about the isthmus which is present in the middle thirds and in the apical third? Now, this can only be negotiated and cleaned through efficient, effective irrigation and no other way. You can also find variations like the apical hook, which are challenging and difficult to deal with. This is another case of multiple portals of exit. C-shaped canals, again an anatomic variation. So, when you use the hand file, your file is actually guiding you through the canal and helping you enlarge the canal so that you pave way and create a path for the rotary instruments which are already pre-programmed to just do their job. And make sure that there isn't excessive torsion, and the rigidity of the file and its cutting ability will determine the propensity to transport a canal. And never work with a rotary file or any file for a very long period of time in the same place, because when you do so, initially it is cutting your dentine, but after that, the flutes get loaded with your debris, and only that portion of the file which is not yet loaded with debris will start cutting. And that is when you have ledges, you have transportations, zips, etc. Get well acquainted with the different hand file motions like follow, follow, withdraw, cut, carve, smooth, patency, and learn the balanced forces of technique of negotiating canals. It works in most of the canals. Also envelope of motion. So all these hand motions using hand files should be mastered before even attempting it on patients. Now, the first step after establishing the glide path is pre-flaring. Pre-flaring can be easily performed with orifice openers. Nowadays, in fact, we have heat-treated files as orifice openers. So even if you don't have a near straight line access to them, you can easily perform pre-flaring. What is the benefit of pre-flaring? You have two images here. You can clearly see that when you pre-flare, you can take a greater volume of irrigant. You can place a larger hand file so you can see the radiograph properly. You can negotiate the apical terminus better. You can also use a larger volume of irrigant, which means better cleaning and shaping, and also you can remove the debris much more easily. Endomotors. Now coming to the rotary systems. Now, when it comes to rotary systems, remember to use dedicated endomotors only for preparing the root canal system. Given below is the gear ratio of different handpieces meant for different purposes. The endo handpiece always has a gear ratio of 16:1. What does this gear ratio mean? It's simple. Gear ratio is the ratio of number of turns the output shaft makes with the input shaft when the input shaft turns once. So suppose a gear set has a 1-inch drive gear and a 2-inch driven gear. It has a ratio of 2:1. So that is how you have to choose your endomotor. Rotary files. Now, selecting rotary files is probably the toughest job in endodontics because you are spoiled for choice with options and everybody is confused which would be the best one for them. Use a file system which is time tested, scientifically tested and approved, which is economical or apt for your budget, which has minimum number of files to practically use it per case, and which can be applied in majority of the clinical conditions to deal with the morphology of the root canal systems. Achieving adequate apical preparation for disinfection without overflaring the coronal part of highly curved canals is one of the greatest challenges in endodontic instrumentation. And this is very true, especially under current concepts of dentine preservation in endodontics. The elegance, I strongly believe in this, the elegance of any instrument is found in its simplicity. What I do in my clinical setup is I stick to one system of files, because when you work with one system of files and repeatedly perform endodontics, root canal treatment, you become very well acquainted with the design of the file, the pros and cons of the file, and also how the file moves in different kinds of anatomies, where it works best, where it doesn't work, everything. So the more you get acquainted and comfortable with that file system, the better will your consistency be, and also will be also the predictability of the results associated with that. Isn't it? So that is the reason, try to master one system of files and choice. I told you how to go about it. Rather than having multiple systems, always declutter your armamentarium. So I stick to one file system. I'm addicted to HyFlex EDM. There are many good file systems, but I'm comfortable with it. I'm able to handle most major variety of root canal cases with that. So I stick to that. And the more I work with it, the more I understand this file system, the more I understand the design of the file system, and I'm able to get consistent results from them. So that is about it. About apical enlargement. The more your apical enlargement is, the lesser will be the debris and bacteria, the lesser debris accumulation from rotary preparation, surface area can be cleaned much better, easier penetration of irrigants, better fluid dynamics, and better chemical disinfection. Suppose you have minimal apical enlargement, then it retains more dentine, so a stronger tooth structure, reduces the chances of fracture, reduces the chances of extrusion of sealers, and safer choice in anatomic limitations. So we can conclude from this that there should be no large or small apical sizes. It should be optimum or adequate apical size based on the biological principles. Irrigation. It is the second most important aspect after mechanical preparation in root canal treatment. So, what exactly happens in irrigation? You are very well acquainted with a fantastic presentation already given on the same, probably the best mentors in irrigation. And we are just looking at it from the point of view of irrigation for a vital tissue in single visit endodontics. The main purpose of using irrigants is as a lubricant, as a disinfectant, and as a chelating agent. And what basically I'm dealing with in vital teeth is collagenous tissue. So your entire focus should be on dissolution by using a lot of sodium hypochlorite. Whereas when you're working on non-vital teeth, you're focusing on reducing the microbial count to controlled levels. Vital tissue is much harder to remove than necrotic tissue. It's more tenacious and it can be easily left behind in the form of tissue tags during the initial cleaning process. Most of the endodontic failures continue to be huge misses of debris, tissue tags which have been left behind in the system. So it's very difficult to get the pulp tissue in toto all the time you're performing single visit endodontics. So what is the function of irrigation in different phases of your treatment? During canal negotiation and enlargement, it acts as a lubricant and facilitates smooth penetration of instruments into those tight canals up to the terminus and helps you flush out the debris. During mechanical shaping to a final taper, it helps you in flushing out the generated debris and dissolving the attached adherent organic fragments. Very important. After mechanical shaping is complete, you're delivering a chemically active irrigant to all the canal surfaces through active or dynamic irrigation. So these are the three phases where you're using irrigation. You have a wide variety of equipment for performing irrigation successfully. But the most important thing is to use a needle which reaches your apical third, a needle which is safe to use, that is closed end with side vents, preferably double vented. They are easily affordable. And if possible, use soft polypropylene needles, which allows the needle to curve and flow through the apical and through the root canal anatomy. And the plastic body also makes the needles atraumatic for hard tissues. Now, gauge is one unit which does not exist in any other endodontic instrument, and that is why there's so much of confusion. What canal size will go with what gauge of the needle? So, according to the ISO 9626 1991 2001 standard, needles with gauges of 21, 23, 25, 27, and 30 present external diameters of 0.8, 0.6, 0.5, 0.4, and 0.3 millimeters. So, you can see that a 30 gauge needle works perfectly for us because we generally have an optimum preparation of around 35.4 for most of our canals, approximately, not always. What do you do with your irrigation? There are so many ways of performing irrigation. Passive irrigation, as shown in the image, where you're not activating the irrigant at all, just depending upon the properties of the irrigant to act. Active irrigation, where you're agitating the irrigant which is present in the pulp chamber and the root canal system and trying to get maximum benefit from each quantity which is dispensed into the root canal system. And you can achieve the same by manual as well as by machine assisted irrigation techniques. Let us have a quick look at the same. Now, always, whatever be your irrigation, make sure that the activation tip does not bind, because the moment it binds to the walls, the benefits of the hydrodynamic effects of irrigation is lost. Apical vapor lock is another problem frequently encountered during irrigation process. So you have your needle which is reaching the apical third and it is depositing the irrigant. The last part of the apical third generally stagnates the liquid. There is no activity here, and as a result of which it creates an apical vapor lock, which can only be sheared by either using manual dynamic activation, where you're using a well-adapted gutta-percha cone, the apical thirds, and activating it, say 100 strokes in a minute, and agitating the liquid and ensuring that it comes in contact with the walls of the root canal. So that's about it. Then the most important irrigant for us in single visit endodontics is sodium hypochlorite. Sodium hypochlorite is one of the probably one of the most popular irrigants used in root canals because of its efficacy in antibacterial action as well as tissue dissolving ability. Here we are focusing on the tissue dissolving ability. It acts by saponification reaction, amino acid neutralization reaction, and chloramination reaction. So our focus now is on the tissue dissolving capacity of this irrigant. Whenever we are using sodium hypochlorite in high concentrations and pH, this leads to increased reaction rate. Reaction rate, we are familiar, we have learned in chemistry. So where the two components react. So if there is an increased reaction rate, your irrigant is quickly depleted, which means you have to frequently keep replenishing a fresh dose of irrigant. Always remember that most of the activity is lost within 2 minutes of contact with the organic tissue, which means, again, it suggests that you keep frequently replenishing your irrigant. Increase in temperature of the irrigant, as we all know, so many popular studies, increases tissue dissolution, which means all these things should be performed to facilitate completion of tissue dissolution. For optimum activity of an irrigant, volume of the solution should be in excess compared to the amount of tissue that is dissolved, which means again you should frequently replenish the irrigant. Frequency and intensity of agitation increases the tissue dissolution. So all that you can see is, in order to achieve optimum tissue dissolution, you have to frequently replenish your irrigant. You have to use it in high concentrations, increase the temperature, and activate it. Now, the surface area in contact with the solution is generally hardly anything. Small part of the pulp tissue only comes in contact with it. Higher concentration always has more of sodium hydroxide. That's why it has its surfactant action. So when it has surfactant effect, it has greater tissue dissolution capacity because it comes in contact with all the bonds. Ultrasonic activation increases tissue dissolving capacity. Laser irradiation increases the tissue dissolution of sodium hypochlorite. There are several studies which also suggest that ozone is also found to increase the tissue dissolution of sodium hypochlorite. Now, what do high temperatures do? They increase the reaction rate of sodium hypochlorite. That means it quickly reacts with the organic tissue, forming ammonia and carbon dioxide. Now, it influences the antibacterial action, means it is increased, and the ability to dissolve the tissue. Reaction rate is nothing but a measure of change in concentration of the reactants or change in concentration of the products per unit time. So which means that if it is high, you have to frequently replenish the irrigant for maximum effect. The speed of a chemical reaction is defined as a change in concentration of a substance divided by the time interval during which the change is observed. Again, it means that if you're having a quick chemical reaction, then frequently replenish your irrigant and have a fresh dose of it every time to hasten the process of tissue dissolution. Sonic activation is definitely good. Ultrasonic activation is considered to be much more effective in achieving the results of disinfection of the root canal. We are already aware of acoustic streaming and microcavitation through which it acts. A quick look at the ultrasonic file. Now, when you have the ultrasonic device, it vibrates in a sinus wave-like fashion. So you have standing waves of maximum displacement, the antinodes, and areas where no displacement, the nodes. So the tip of the instrument exhibits an antinode. Now suppose if you were to power it to very high with no contact in the walls, the instrument will definitely break because of intense vibrations. And that is probably one of the reasons why many of the people who approach me have fear to use ultrasonic files in the root canal for activation, because they fear that it will break. So the clinician should smartly use it for short intervals of time, passively, and you have to carefully control the power. In one of the presentations, already settings and everything is clearly explained. Breakage normally occurs at the nodes of the vibration. Now coming to cavitation and acoustic streaming, which are the physical effects of ultrasonics. Now during oscillation of the file, the fluid has a positive pressure phase and a negative pressure phase. So if the file's tensile strength is exceeded during oscillation, then a cavity is formed in the liquid in the negative phase. And in the next positive pressure phase, that cavity implodes with great force, leading to cavitation. And so there is aggressive movement of fluid around the file tip, leading to increased activity of the irrigant. So cavity and acoustic streaming are based totally on free vibration of the file. It should not come in contact or restrained by the walls of the cavity. Depending on the size and power, the file tip may have amplitudes that will require a canal size of say 30 or 40. Otherwise, the free oscillations are dampened, which means the effectivity of ultrasonic agitation is also lesser. So smartly work with a small sized file with minimal contact with root canal walls and set it at optimal settings to get optimal cleaning with the same. Now, we all have to acknowledge that sodium hypochlorite is a great antibacterial agent and a tissue dissolving agent. EDTA and citric acid are great chelators, but none of them are complete as an irrigant. And so even in single visit endodontics, you have to follow the irrigation protocols mentioned, where you will alternately use sodium hypochlorite, saline followed by EDTA or citric acid for specific intervals of time to achieve complete disinfection or near complete disinfection of the root canal system. Now, one of the biggest challenges that we encounter when we perform irrigation by using alternate irrigants is that whenever one irrigant comes in contact with another, its efficacy is reduced. Now, every time you can't keep using saline, or you can't keep putting paper points to, say you are wasting a lot of time. So you can use tools for aspiration like Surgitip. which completely eliminates the irritant from the canal prior to introducing another, and you're saving a lot of time. It hardly takes a few seconds to use a surgery tip and completely suck out the previous irritant and introduce a new irritant into the canal. So that is time saving, and that is very vital when you're performing single visit endodontics. Obturation. Once you have completed the disinfection process and dried the canals, it is ready for obturation. The purpose of obturation is to block, obstruct, gore, stop, occlude the root canal system apically and coronally. It is an attempt to seal all portals of re-entry of microorganisms into the root canal system and prevent provision of nutrients to the remnant bacteria in the cleaned canals. There are two important elements which we must consider when judging the value of total obturation of the root canal system. First of all, accept it that there is inability to know with certainty whether the apex has been sealed in a non-surgical root canal treatment. The existence of numerous accessory canals, many of which may contain significant potential for production of a lateral root abscess. Root canal obturation is performed with a combination of sealers and a solid core, generally gutta percha. The sealer fills the space the solid core material is unable to fill because of its physical limitations. Sealer is coated only in the apical third of the root canal, and excess sealer can be easily removed using dry paper points. Sealer which has spread on the pulp chamber floor can be removed with citric acid. Now, with regards to or with relevance to single visit endodontics, there is one thing that I would like to mention about sealers. Most of the sealers, such as epoxy resin based, calcium hydroxide based, zinc oxide eugenol based, possess a marked cytotoxic ability and tissue irritating potency to the periodontal ligament cells. And as I've already mentioned initially, do no harm. You're not a creator. Do no harm to what was normal. So as far as possible, in their unset state, they are toxic. So as far as possible, limit your work to within the root canal system. Limit the material to within the root canal system. Most of the currently used sealers are known to have some mutagenic effects whenever overfilling occurs. Now, mutagenic effects is actually changing the pattern of cells. So try to do no harm. The final taper of preparation is critical in the sealing ability of obturating materials. The primary objective of obturation is to achieve a fluid-tight seal at apical, lateral, and coronal sections of the root canal system through various obturation techniques. Now, the core, the semi-solid core which is used is gutta percha in most of the cases. And we know gutta percha exists in two phases, the alpha phase and the beta phase. Alpha phase is a natural version which is extracted from the tree, and the beta phase is the commercial version, which is a combination of 20% gutta percha with 60% zinc oxide and resins and waxes, etc. Now, we use gutta percha sticks, which are beta phase, and alpha phase is used in more vertical. So a few things which I would like to mention. Most of the operators, most of the clinicians in the initial stages, now I was told that I will be addressing mostly beginners, which is why I have presented it in this way. So most of the beginners, even after learning, mastering how to use rotary files, struggle with selecting the master cone. Although they have prepared it to a size 40, they realize that the gutta percha cone is not going to size 40. I mean, it's not going to full working length. Why? The gutta percha cone is a soft, semi-rigid substance, while your file is rigid. So when you place the gutta percha to full length, because of its softness, it will bind somewhere along the long axis and collapse because of lateral resistance. So you'll never be able to place your gutta percha to full length, especially if it's a 2% obturation. Now, what is the solution to this? Because you have to complete your task in one visit. You don't have time to have the session next time or try different cones, etc., to get the best fit. The master gutta percha cone selection. Original piece of gutta percha must be carefully selected so that its taper is more gradual compared to the preparation taper. So that way, the chances of it buckling will be lesser. Also, avoid gutta percha cones which are too pointed, because they'll end up binding themselves somewhere along the length of the canal and never near the apex. And it will never give you the density of gutta percha which you need at the apical third. It is preferable to cut off the apical end of a less heavy gutta percha cone than to select a heavier gutta percha cone with a fine tip. In any event, the apical end of the master gutta percha cone must be wider than the apical end of the root canal. This is why we generally inform vertical compaction. We are trimming 0.5 to 1 mm of the apical end of the gutta percha, because when we obturate, we are compacting the gutta percha. We are trying to have maximum density of gutta percha in the apical third so that it gives you a beautiful seal and it flows into the finer details of your root canal anatomy. Now, for beginners who are struggling with the selection of master cone, instead of working with non-standardized cones, if they are following a particular file system, you always get dedicated paper points and gutta percha for that specific system. And if you were to use a dedicated gutta percha, which is of the same dimensions as the last rotary file that was used to prepare the root canal, it conforms beautifully to the anatomy and gives you a perfect fit. So you are wasting lesser time in selecting the master cone, so you can execute the task of obturation in a stipulated period of time within the comfort levels of the patient. One more important thing, the root canal system can be flooded with 95% ethyl alcohol and then dried with paper points. The alcohol flooding and drying removes the organic and aqueous material which is present along the walls of the canal. We are dealing with inflamed vital tissue. So that further ensures maximum tissue dissolution just prior to obturation. The final test of a root canal filling is its capacity to seal off the root canal system from the periapical tissues. Execution of obturation would best be performed by using simple obturation techniques as suggested in the presentations exclusively dedicated to obturation, where hydraulic condensation technique has been mentioned as a single cone technique, and using bioceramic sealers, you're ensuring a good healing with simple obturation technique. Suppose you're keen on using warm vertical compaction, you will have to reduce the heating element temperature to 150 degrees to execute the task. Remember, the key is aseptic conditions. There is always a possibility of introducing microorganisms through instruments, gutta percha, etc. Remember, after choosing the master cone, the gutta percha has to be disinfected by placing it for a minute in high-strength sodium hypochlorite solution, after which it is wiped clean with ethyl alcohol to remove the crystallized structure of sodium hypochlorite prior to obturation. So do not inoculate the root canal with fresh microorganisms after completing the entire process step by step perfectly. And most importantly, do no harm. With regards to armamentarium, the tools are only as good as the man or woman who wields them. And this is very important, especially in single visit endodontics. In conclusion, single visit endodontics is a procedure that supplements and complements total patient care related to endodontics. And it is not a technique that can totally replace multi-visit procedures. Both multi-visit treatment and single visit treatment should be viewed as a part of a total endodontic spectrum of options, the choice of one over the other being determined by the circumstances surrounding individual cases. The practitioner should not routinely apply only one technique to all the situations, but rather evaluate the circumstances peculiar to each particular case and then choose the technique that best fits those circumstances. However, when doubt exists, it is always better to opt for a multi-visit procedure and not opt for a single visit. So the clinician will be most effectively utilizing his time in delivering the best possible endodontic service available to the patient. So the path is clear for those who choose to follow. And always remember, do no harm. Thank you very much for your kind attention.